السلام عليكم. إن شاء الله أنا هتكلم عن mechanism of labor. Labor defined as series of events that take place in the genital organs in an effort to expel the viable product of conception, which is composed of fetus, placenta, and membranes, out of the womb through the vagina into the outer world is called labor. Labor differs from delivery, which is expulsion or extraction of viable fetus out of the womb. Delivery can take place without labor as in elective section. الدليفري كترمينولوجي هو أشمل من الليبر can include vaginal delivery and cesarean section. Labor is called normal if it fulfills the following criteria: spontaneous onset, not induced, at term, not preterm labor or post-date or post-term, with vertex presentation يعني كفالي with vertex presentation, without any prolongation لأن في prolonged labor وفي precipitated labor. تمام. ف without prolongation with reasonable time. Natural termination with minimal aids to be spontaneous as possible without having any complications affecting the mother or fetus, without any complication intrapartum or postpartum. دي الكرايتيريا of normal labor. طيب labor pain في true labor pain and في Braxton Hicks. تمام. True labor pain defined as presence of strong regular painful contractions resulting in progressive cervical change and descent of the presenting part. true labor pain بيكون continuous بيكون regular بيزيد في intensity and frequency. Braxton Hicks, its contraction mild, often irregular, non-progressive contractions that may occur from 30 weeks gestation or more common after 36 weeks and may often be confused with labor, but it's irregular non-progressive ما هتزيد في الintensity ولا في الفريكونسي، هتكون حاجة irregular بتجي on and off، ما فيها cervical change، ما فيها descent of the presenting part. طيب قبل ما نتكلم عن mechanism of labor لازم نعرف ال stage of labor. تمام. ناخد كلو عن الليبر بعدك هنبدأ في الميكانيزم إن شاء الله. Stages of labor. Events of labor are divided into 3 stages: first stage, second stage, and third. A recent added the fourth stage of labor. First stage, it starts from onset of the true labor pain and ends with full dilatation of the cervix. Second stage, it starts from full dilatation of the cervix and ends with expulsion of the fetus from the birth canal. The delivery of the fetus occurs in the second stage. Third stage of labor, it begins after expulsion of the fetus and ends with expulsion of the placenta and membrane. Delivery of the placenta occurs at the third stage of labor. Some reference at the fourth stage is the stage of observation for at least 1 hour. Type in details. First stage, this describes the time from the diagnosis of labor and onset of true labor pain to full dilatation of the cervix. The full dilatation at 10 centimeters height. تمام. The first stage of labor can be divided into 2 phases: latent phase and established phase. Latent phase is the time between the onset of regular painful contraction, true labor pain, and 3 to 4 centimeters cervical dilatation. The full dilatation at 10 centimeters divides the first stage into 2 phases according to cervical dilatation. Until 4 centimeters of dilatation, it's called latent phase. From 4 centimeters until full dilatation of 10 centimeters is established phase. During this time of latent phase, the cervix becomes fully effaced. لكن الديليتيشن بيبقى fully dilated at the end of the established phase, but full defacement occur at the end of the latent phase. What's the effacement? Effacement is a process by which the cervix shortens in length as it becomes incorporated into lower uterine segment. مثل shortening the cervix and included in the lower uterine segment. This is what called effacement. Second phase of first stage of labor called established phase, when there are regular contractions and there is a progressive cervical dilatation from 4 centimeters. This picture demonstrates cervical effacement as we see in A. This is cervix, this is the vagina, and this is the uterine cavity. Cervix start to be shortened here and here, incorporated in the lower uterine segment, and will be paper-like, phased and thin. This part starts with dilatation before effacement. This occurs in multiparous women. In primary gravidas, occur effacement first before dilatation. The length of established first stage of labor varies between women. Latent phase بنحسبه is not continuous phase and can be prolonged until days. The length of the established first stage of labor varies between women. First labors, primary gravidas, last on average 8 hours and are likely to last over 18 hours. 8 hours is the average, and more than 18 hours is prolonged labor for primary gravidas. Second and subsequent labors last on average 5 hours and are likely to be last over 12 hours. But roughly, cervical dilatation typically at 1 centimeter per hour or more in a normal labor, more than 1 centimeter in 1 hour, at least 1 centimeter, but it's only considered abnormal if it occurs less than 1 centimeter per 2 hours. This is regarding established first stage of labor. If the cervical dilatation less than 1 centimeter per 2 hours, suspect failure to progress or prolonged labor, and when suspect delay or failure to progress, we have to take an action and observe the mother and reassess her to confirm failure to progress or not. To confirm failure to progress or not. Second stage of labor, which is from full dilatation of the cervix to expulsion of the fetus. Second stage subdivided into 2 phases, passive and active phase. Passive phase, where there is full dilatation of the cervix before or in the absence of involuntary or active pushing. بيكون cervix fully dilated لكن but the mother don't have the urge to push or pelvic maneuver. When the active phase starts, either when the baby is visible or there is involuntary or active pushing with full dilatation of the cervix, this is diagnosed active second stage of labor. Duration of the active second stage depends on puberty and if the patient have epidural or not. In a leprous woman without an epidural, it's expected to be delivered 3 hours after start of the active second stage. الباسيف phase ما محسوب هنا. تمام. The leprous with an epidural, be aware that this woman may have had passive stage of up to 2 hours after full dilatation before commencing active pushing. So the leprous woman with epidural expected to be delivered 3 hours active. It's also expected to be delivered 3 hours after the start of the active phase, but the active phase will be delayed 2 hours by the epidural. So the leprous woman with an epidural we expect to deliver 3 hours after start of the active second stage of labor also, but will be delayed 2 hours in a passive stage if have an epidural. For a multiparous woman without an epidural, delivery will take place after 2 hours of start of active second stage. If patient have an epidural, this will be delayed 1 hour during the passive stage. Third stage of labor, which is delivery of the placenta, is the time from birth of the baby to the expulsion of the placenta membranes. Diagnose a prolonged third stage of labor if it's not completed within 30 minutes of birth with active management or within 6 minutes of birth with physiological management. Duration of the third stage depends according to management of third stage, either active or physiological. Maximum 60 minutes in physiological management and 30 minutes during active management. طيب what is an active and physiological management? Active management of third stage involves routine use of uterotonics. Its drugs cause uterine contraction, cord clamping and cutting of the cord, controlled cord traction after sign of separation of the placenta. This is active management بيكون في action أنا باخده، لكن في physiological management بيكون observation, just observation. No uterotonics, no clamping of the cord until pulsation is stopped or after delivery of the placenta, and delivery of the placenta that will be spontaneous or by maternal effort, ما في control cord traction. According to the maternal wish and the general condition or comorbidity of the mother, can offer active or physiological management. Is the patient anemic or have another risk for bleeding and postpartum hemorrhage, will not offer physiological management أصلا. تمام. According فالactive management فيه side effect of nausea and headache due to medications، لكن فيه less blood loss. طيب we'll start mechanism of labor. Defined as series of changes in position and attitude that the fetus undergoes during its passage through the birth canal. Series of changes in position and attitude of the fetus. Fetal head. هنتكلم عن الكيفاليك vertex presentation and gynecoid pelvis. تمام. In this definition we mention position and attitude and presentation. So we revise some terminologies and add the new one before we start this part of lecture. Obstetric term. Attitude is the relation of the fetal parts to each other, either flexion attitude or extension. Flexion in the majority of cases and extension in face presentation. Lie is the relation between the lung axis of the fetus and that of the mother. Relation of the fetal parts to each other is attitude. The relation of the fetal axis with the mother is a lie. Longitudinal lie in cephalic and breast presentation. Transverse or oblique lie in shoulder presentation. فالlie either longitudinal or transverse. Attitude either flexion or extension. The denominator, as we mentioned earlier, it's bony landmark on the presenting part used to denote the position. A denominator used to determine the position. In vertex, denominator is occiput. In face it's venta, breech it's sacrum, in shoulder it's scapula. Position. What's the position? Is the relation of the fetal back to the right or left side of the mother. هما fetal back whole relation of the denominator. تمام. To the right or left side of the mother and whether it's directed anteriorly or posteriorly. قلنا majority or more than 95% of the vertex presentation is occipital anterior. A denominator whole occiput والmost common position is anteriorly. Occiput بيكون directed towards the pelvis. Presentation. The part of the fetus related to the pelvic brim and first felt during vaginal examination أو is the lowermost part of the fetus. The presentation. Engagement هو passage of the widest transverse diameter of the presenting part through the pelvic inlet or pelvic brim. In vertex presentation, the widest diameter is a biparietal diameter, which is 9.5 centimeters. Station is the relation of the most prominent leading part of the presenting part to the ischial spine. At ischial spine is 0 station, above is minus station, and below ischial spine is plus station. الكلام ده كله revision كان في lectures اللي قبلها. طيب Mechanism of labor. There is a principal movement or cardinal movement of mechanism of labor. First, start with engagement, which is the passage of the widest diameter of the presenting part through the pelvic ellipsa. Descent, flexion, internal rotation, crowning, extension, restitution, external rotation, and expulsion of the trunk. هنتكلم عنهم in detail. This picture demonstrates the mechanism of labor. In summary, A is engagement. A demonstrates engagement with the passage of the widest diameter, transverse diameter, through the pelvic ellipse. This is widest diameter or biparietal diameter. B is a descent. This picture demonstrates the descent. In C, this is the start of flexion attitude of the head, then internal rotation. In D, this is internal rotation of the occiput from occiput transverse to occiput anterior position. In E, it's extension, delivery of the head by extension to deliver the occiput underneath the symphysis pubis. This is the delivery of the trunk. First, engagement. In normal labor, the head enters the perineum more commonly through the available transverse diameter. In the pelvic brim or pelvic length, as we mentioned, the transverse diameter wider than anterior posterior diameter. So the presenting part will engage in transverse diameter and whole widest, taking advantage of the widest pelvic diameter. The engaged anterior posterior diameter of the head is suboccipito-brygmatic 9.5 cm. The engaging transverse diameter is biparietal 9.5 cm, as the occipitolateral position is the most common. The mechanism of labor in such position will be described. Baby will be engaged in occipito-transverse or occipitolateral position. The presenting part or the engaging diameters in anterior-posterior هو suboccipito-brygmatic وفي transverse diameter هو biparietal diameter 9.5 by 9.5. Syncretism. As we mentioned, the engaging diameter will be biparietal diameter, but in fact, the two parietal bones will not cross the pelvic brim at the same time. This is called syncretism. Syncretism, the picture in which the two parietal bones are at the same level. To decrease the diameter furthermore, position of asyncretism. It is the position in which one parietal bone is at a lower level than the other due to lateral inclination of the head. By this, the baby will decrease diameter from biparietal diameter 9.5 cm to subparietal, which is 8.5 cm. This is called asyncretism. This picture demonstrates syncretism and asyncretism. B demonstrates syncretism in which the biparietal diameter and two parietal bones cross the pelvic brim at the same time. A and C, this is what we call asyncretism. Parietal eminence will cross the pelvic brim first. This is called anterior parietal and this is posterior parietal. Advantage of asyncretism. Engagement of the head with asyncretism. The two parietal eminence cross the brim at one time. This helps lesser. Asyncretism will help lesser diameter super subparietal, which is equal 8.5 cm, to cross the pelvic brim instead of large biparietal diameter 9.5 cm. Marked and persistent asyncretism is abnormal and indicates CPD, cephalopelvic disproportion. This is biparietal diameter and this is super subparietal diameter. Descent after engagement, first stage of mechanism of labor. Second, descent. Descent is a continuous process. It's slow or insignificant during the first stage, but pronounced in the second stage due it's assisted by voluntary effort of the middle abdominal muscle and Valsalva maneuver. During the first stage it's by uterine contraction, but during the second stage it's aided by abdominal muscle. It's complete with expulsion of the fetus. It's a continuous process from the engagement until the expulsion of the fetus and the end of the second stage. Descent from the inlet until the outlet. Flexion. While some degree of flexion of the head is noticeable at the beginning of the labor, but complete flexion is rather uncommon. الاتيتيود of the patient is flexion، والفlexion هو اللي بيديني smaller diameter في الفيتال skull، لكن no full flexion during the beginning of the labor. Flexion will be increased during first stage of labor. Thus, if the pelvis is adequate, flexion is achieved either due to resistance offered by the unfolding cervix, the wall of the pelvis, or the pelvic brim. Mechanism of flexion either by the cervix or the bony part of the pelvis or muscle diaphragm. This is the pelvic diaphragm. Flexion is essential for descent. Non-flexion between lesser diameter, lesser presenting diameter, and the descent will be easy, since it reduces the shape and size of the plane of the advancing diameter of the head. The flexion reduces shape and size of the diameter of the head, so the descent will be easier. Internal rotation. Internal rotation explained by two theories. First, slope of the pelvic floor. Second, pelvic shape. Slope of the pelvic floor. بما ان pelvic floor احنا عارفين بتكون من ال levator ani muscle which is directed backward and toward the midline. During each contraction, the occiput stretches the levator ani, but this stretch made by the elastic recoil of the levator ani, a resistance. This will bring the occiput forwarded towards the midline, and this process will be repeated until occiput will be directed anteriorly. يبقى البوزيشن من occiput transverse to occiput anterior. The second theory هو pelvic shape. The forward inclination of the side walls of the pelvis. In this image, the pelvis directed forward as illustrated here. Pubic tubercle and anterior cervical spine will be in the same plane. This forward inclination of the pelvis and the narrow mid cavity اللي هو باي spinous diameter اللي بيكون في الميد cavity will direct the occiput and engaging diameter to adapt the anterior posterior diameter, which is the widest diameter in the outlet. So the baby will escape narrow bispinous diameter and long anterior posterior diameter of the outlet, result in putting the long axis of the head to accommodate the maximum available diameter, اللي هو anterior posterior diameter of the outlet, leaving behind the smallest bispinous diameter. By the end of internal rotation, the occiput will rotate anteriorly 1/8 cycle, so the sagittal suture now lie in anterior posterior diameter, while widest diameter at outlet. If shoulder is still in anterior posterior diameter, the neck will sustain torsion, and so there is simultaneous rotation of the shoulders in the same direction of internal rotation and will be in the oblique line. By the end of internal rotation, occiput will be occiput anterior and the shoulders will be in an oblique line. Crowning. After internal rotation of the head, further descent, then we're going to have continuous process. Further descent occur until the occiput lie underneath the pubic arch. At this stage, maximum diameter اللي هو vibrator stretch the vulval outlet without any recession between contraction. This is called crowning, like crown overhead. Extension. Delivery of the head take place by extension through couple of force theory. Uterine contraction force toward downward and forward, and the resistance of the pelvic floor by upward and forward. So the net result of action is extension of the head by forward direction. This picture demonstrates descent and flexion of the head followed by internal rotation and end by extension. the engagement in occiput transverse position from occiput transverse at this time of engagement to occiput anterior. His occiput will lie under the symphysis pubis. This is symphysis pubis and this is occiput anterior position. After internal rotation, the head will be developed with extension to bypass this symphysis pubis by extension. Restitution. Movement of restitution occur rotating the head through an SF cycle in direction opposite to that of internal rotation. At internal rotation from occiput transverse to occiput anterior position. تمام. After develop the head by extension, there will be restitution at the opposite direction of internal rotation. So from occiput anterior position, after delivery, we'll adopt the occiput transverse position, opposite direction of internal rotation. The head aligns itself with shoulders which have entered the pelvis in oblique direction. يبقى قلنا إنه الهيد بيبقى occiput anterior بانتيريور rotation والshoulders has a simultaneous movement and will be at oblique direction. The head will align itself with the shoulders to deliver the shoulder, and the slight rotation of the occiput through one edge of the cycle called restitution in opposite direction of internal rotation. External rotation. In order to be delivered, shoulders have to rotate into a direct anterior-posterior diameter. لأن outlet هو widest at anterior-posterior diameter. The shoulders to be delivered will be at AB plane. When this occurs, the occiput rotates through the further 1/8 of the cycle in same direction as restitution to transverse position. During internal rotation, this movement 2/8 of the cycle will be counteracted by restitution and external rotation. Restitution is in opposite direction at 1/8 of the cycle and will be completed by external rotation at the same direction of restitution with 1/8 of the cycle also. The net action is 2/8 of the cycle and opposite direction of internal rotation. External rotation when external rotation occurs, the occiput rotates through the further 1/8 of the cycle in the same direction of restitution to the transverse position. الهيد برجع على الأوكسيبيتو transverse position اللي كان فيه في الانجاجمنت أول. External rotation of the head after delivery of anterior shoulder rotate forward to pass the anterior arch. This explains external rotation. Baby delivered by extension and occiput anterior position. Then by restitution 1/8 of the cycle and external rotation another 1/8 of the cycle, baby will be shifted from occiput anterior to occiput transverse. تمام. And the shoulders will be at anterior posterior diameter from oblique direction to anterior posterior diameter. The shoulders will be anterior shoulder and posterior shoulder will align itself with the maximum diameter of the outlet, which is anterior posterior diameter. The next step is pairs of shoulders and trunk. After the shoulders are positioned in anterior posterior diameter of the outlet, further descent takes place until the anterior shoulder is kept below the symphysis pubis first. If any abnormality or delay in this step, this will be suspected as shoulder distortion. Will be discussed later inshallah. طيب. By a movement of lateral flexion of the spine, the posterior shoulder sweeps over the perineum. Rest of the trunk is expelled out by lateral flexion. Pairs of shoulders and trunk could be by the action of lateral flexion. If delayed more than 60 seconds, This is suspected as shoulder dystocia. In summary, we talk about labor, stages of labor, first stage, second stage, and mechanism of labor will be during the first and second stage. Third stage, delivery of the placenta, and fourth stage for observation. In summary, the principal movements are engagement, descent, flexion, internal rotation, crowning, extension and restitution, external rotation, and expulsion of the trunk. Thank you.